also wearing sweatpants, and so this whole thing is new to all of us in terms of format. But anyway, thank you for joining me. Thank you for joining me during happy hour. Hopefully you've got a glass of wine to accompany this lecture, and hopefully it will be useful and entertaining. The topic of my talk is back pain. When is surgery warranted? And in terms of format, I'm going to go through a couple of surgical indications, a couple of surgical techniques, and then there will be opportunity at the end of the talk, if you have any questions, to type them into the Zoom chat, so this can be a little bit more of an informal discussion. A little bit about myself and my practice. So I grew up, I'm actually from Canada originally, but I grew up in Brookline. I went to Harvard undergrad as a biology major, and then UMass Medical School. And then I was an intern and resident at University of Pittsburgh Medical Center. I had an additional lab year in spine surgery during residency. And then I went on to fellowship in spine surgery at Emory. And then I came to Plymouth to practice. I've been here since 2014 as a partner at Plymouth Bay Orthopedic Associates. I'm board certified in orthopedic surgery, and I specialize, my elective work is all in exclusively spine surgery. And I have no particular disclosures for this talk. I'm focusing specifically on the lumbar spine, the low back, so as opposed to cervical and thoracic issues, which are essentially a different entity. I'm really going to focus on back pain. And I wanted to focus on degenerative conditions. So within a spine practice, there are typically, I'd say typically about 90% of the problems one might encounter are degenerative or arthritic in nature. And then the other 10% are less common causes of back pain, such as trauma, injury, infection, cancer, deformity, and inflammatory or autoimmune conditions. Those are all the more rare forms, but this talk is specifically about degenerative or arthritic conditions causing back pain and when surgery might be warranted. And I wanted to, through the course of this talk, dispel two myths or fallacies about back pain and spine surgery. And the first myth that I wanted to dispel was that if back pain is severe enough, then surgery must be the option. It's kind of like surgery is the nuclear option for very severe back pain. And that's dangerous thinking. And what I'm hoping to show you is that really surgery is potentially the right answer for a certain subset of conditions, but surgery is not the right answer for other types of back pain, no matter how severe that back pain may be. And the other myth that I'm hoping to dispel is everybody knows somebody who's had back surgery and may not have had a great result. And so this is, particularly 10 years ago, 15 years ago, it was within the community, don't have back surgery because you'll never get good results. And that's also untrue. There's very good evidence to support that if you do the right operation for the right reason, that you can have very good results. But if you do the wrong operation for the wrong reason, then the results are not good. So I will circle back to that at the end of this talk. I'm going to focus primarily on lumbar disc herniation, lumbar stenosis, and spondylolisthesis as the three main surgical entities. I'll go through these one at a time and describe some of the anatomy and the pathology. So first, sciatica. What is sciatica? Sciatica specifically means nerve root compression in the lumbar spine, causing radiating leg pain. And so sometimes to the layperson, when they say they have sciatica, they may mean something else. They may mean back pain. They may mean sacroiliac joint dysfunction, something non-specific. But sciatica is typically pain that emanates from the back, it radiates down the leg, and it will usually, but not always, go down to the calf and foot. And I say that because it really depends on which nerve roots are involved. The nerve roots in the lumbar spine or the low back within the spinal canal, when those are compressed, those nerves radiate down to the leg. So nerve root compression in the low back causes radiating leg symptoms of sciatica. Sometimes this can also cause numbness in the leg and foot. And sometimes, if it's bad enough, it can also cause weakness in the leg. And there's another condition called claudications, neurogenic claudications. Big words, but what it specifically means is due to nerve compression in the back, in the lumbar spine, walking long distances becomes problematic because the legs begin to feel tired and heavy. And that is called neurogenic claudications. And it is also specifically related to nerve root compression in the lumbar spine. So the first entity that I wanted to discuss as a potential surgical indication is a lumbar disc herniation. The intervertebral discs are the shock absorbers that live between each of the vertebrae. The vertebrae are the bones within the spine. And what you can see on this animation here, this cartoon, here we see a vertebral body, a bone in the lumbar spine, and then here's the one below. And these bones are designed to articulate or move, and that allows you to flex, extend, and twist. And in between each of those bones, what permits some of that motion is this unique structure within the body called the intervertebral disc. This tissue is not found anywhere else besides the spine. It consists of, in the cross-sectional view here, an outer wall called the annulus, and then which is firm, and then an inner part called the nucleus pulposus, which is soft and squishy. And so that's designed to cushion each of these bones against the one above and below. Now, of course, within the spinal canal, the nerve roots have to pass right through this area. And so if one of the intervertebral discs is disrupted and herniates, then that herniated disc material can compress a nerve root. So you should think of the disc like a jelly donut. If you have a jelly donut and slice and then squeeze, some of that gelatinous material can extrude out. And if extruded into the area of the nerves, compressing the nerves, then that mechanical compression along a nerve root will cause nerve pain, which will cause sciatica, radiating leg pain, possibly numbness or weakness. Interestingly, it's not just structural compression that is the problem here. In addition to structural compression, there is also an inflammatory response. So anytime the body has an injury of any type, there is inflammation, which is irritation at the molecular and cellular level. And so in order to get nerve pain, you have to have both structural compression as well as inflammation. And you can see an example of a disc herniation here on this MRI, a normal looking disc. So we're looking at the spine from the side. We see bone here and disc here. A normal looking disc is light in the center and dark in the periphery, such as this one here and this one here. But at L4-5, this level right here, you can see this disc is very different from the one above. It's darkened, it's collapsed in terms of height, and as a result of that, it is extruded, or there's disc material that is now within the spinal canal and at risk of compressing the nerves. So when a disc herniation occurs, it can be as a result of an injury, but the vast majority of cases, it just happens. Twisting, coughing, sneezing, straining, and then all of a sudden, very severe back pain and associated radiating leg pain. It's usually unilateral. One leg is worse than the other, but not always. And in the majority of disc herniations, we initially try conservative management, which is anti-inflammatory medications such as Aleve or ibuprofen, physical therapy or some form of manual therapy such as physical therapy, chiropractic, or at least a home exercise program. And the goal of all of that is to try to slow things down to allow the patient to slowly get better on their own, because 80% of the time, a disc herniation will resolve on its own and not require surgery. And the reason for that is the body reabsorbs that extruded disc material. It will shrink down the extruded disc material and the inflammation settles down, and then the symptoms can go away. So typically, initial management for a disc herniation is conservative, with the goal of trying to get the patient more comfortable so that they can wait 6 to 8 weeks to see if this is going to go away on its own. So as part of conservative management, certainly physical therapy, medications, we might try oral steroids like prednisone, sometimes nerve pain medications such as gabapentin, which is also called Neurontin. And then if things are not going well, the next step might be to consider a spinal injection, an epidural injection, which delivers local steroid medication right to the area of the herniated disc. And none of these things in and of themselves can shrink that disc. The steroid medication, the chiropractor, none of them can make that disc herniation go away. Your body makes that disc herniation go away over the course of time. And the goal of care initially is to try to help you achieve reasonable comfort while you wait this thing out. Now, there are some rare circumstances where we may have to skip conservative management because the disc herniation is too large and the neurological problems are too severe. So if you get a very large disc herniation compressing the nerves in the lumbar spine, then you can get significant leg weakness, potentially bowel or bladder incontinence. That's an emergency called cauda equina syndrome. And that's really a different entity. In that case, there's no role for conservative management. That disc has to be removed surgically, urgently. But that's an extremely rare scenario where the disc herniation is so massive that it just crushes all the nerve roots in the vicinity. The majority of the disc herniations are in the small to moderate size. They can cause very severe sciatica pain, but not a neurological emergency. So we try to wait them out if at all possible. The most common levels for a disc herniation are L4-5, which is right about the belt line in the lumbar spine. And second to that is L5-S1. And so that would contact a nerve root, and then it would affect either, depending on which level is involved and the location, either the L4, the L5, or the S1 nerve root. And the nerve root distributions are seen here, radiating down the leg. The L4 is the inside part of the calf, L5 is the front of the shin to the top of the foot, and S1 is the back of the leg. So sometimes even without an MRI, based on the distribution of pain, one can determine which level is likely to be involved. Now, if conservative management has failed, meaning you've tried physical therapy, anti-inflammatory medications, potentially a steroid injection, although that's not required, then one might consider surgery to remove the disc material, and that's called a microdiscectomy. That's an operation done under general anesthesia, very small incision, it's minimally invasive. And then we get right to the level where the problematic disc is, make a small window in the bone so that we can access the spine from the back, gently move the nerves out of the way as is depicted here, and then we can reach through and take away that extruded disc material. We leave the healthy disc behind. We try to leave behind as much disc material as possible, just removing the part of the disc that was within the spinal canal compressing the nerves. A microdiscectomy typically is a brief procedure. Usually it can be done in about an hour. Quite often it's done as day surgery. And usually there's pretty significant relief in leg symptoms, meaning sciatica, right after surgery. Of course, there's post-surgical back pain from just the operation itself, which goes away over a couple of weeks, but the relief in leg symptoms is very quick. This is a different entity called lumbar stenosis. So stenosis means narrowing of the spinal canal, and that stenosis typically happens due to arthritic structures within the canal, either the disc protruding back, or there is a ligament on the inside of the spinal canal called the ligamentum flavum, which with arthritis can get bigger and cause nerve root compression. But anything that narrows the spinal canal causes stenosis. And in turn, stenosis can then cause symptoms you already have heard about, which is sciatica and neurogenic claudications, which is again leg pain or tired with trying to walk long distances. Here's an MRI on your left depicting normal in cross section. So imagine on this MRI panel, we're slicing like a loaf of bread so we can go straight down the spinal canal. This is the intervertebral disc right here. This is the spinal canal outlined in yellow. The dots are the nerve roots and the white is spinal fluid. And so what we're showing you is a normal and healthy level. The skin of the back is down here below. These are the back muscles that you can feel. And then the abdominal contents are up higher. But this is what normal looks like. This is what stenosis looks like. And you can see by comparison, significant narrowing of the spinal canal. All of those nerve roots are crowded into this area and being compressed and crushed. So again, with stenosis, as with the lumbar disc herniation, you first initiate conservative management, typically physical therapy, anti-inflammatory medications, possibly a spinal injection. I will say that sometimes when the amount of stenosis or nerve compression is too severe, sometimes we would not recommend a spinal injection because that injection is a small volume of fluid, a couple of milliliters, and that can take up more space and cause compression. So the injections, the epidural spinal injections, are best for the stenosis that's in the more mild to moderate range. But if the stenosis is very severe, the injection may not be a good idea. At best, it may not work, but at worst, it may actually make the problem worse. So when someone has failed conservative management, then the operation of choice for stenosis is called a laminectomy. Laminectomy means removing the roof of the spinal canal, opening up space for the nerve roots. So here you can again see in cross section, here's the intervertebral disc. These are the nerve roots. The skin from the back is here. The abdominal contents are in front. So in a laminectomy, we've approached from the back and we've taken off the roof. This bone here is called the lamina. In removing the roof, that opens up the space for these nerve roots, and so they're less crowded. And we can gently reach in and remove the ligament on the inside called the ligamentum flavum. So here's a view in cross section, and then here's a view from the surgeon's perspective looking down on the spine once the lamina has been removed. These are the nerves, and this is the vertebral body, the lamina above and below. Pardon me. On this MRI in cross section, again, very severe stenosis, but the goal is to make it look like this, to open up this space so that it looks like this once more. Laminectomy can be one level or multiple levels, depending on how many levels are problematic. If it's one level, it's a fairly quick operation and can sometimes be done as day surgery. But if it's multiple levels, then it may require an overnight or even 2 or 3, depending on how involved. The third entity that I wanted to discuss is spondylolisthesis. Spondylolisthesis is degenerative instability. So if you look at this upright or standing X-ray, you can see the spine from the side. Here's the L4 vertebral body, here's the L5 vertebral body, and there is this step off in between. All of the other vertebrae connect like this as a normal cascade, and then there's a step off right here. That's a fairly common condition called spondylolisthesis. It occurs when there is some degeneration within the disc space and some arthritis within the small joints in the back called the facet joints. And as a result of that, things get a little bit loose and one vertebral body gradually and slowly slides forward on the one below. The reason that's a problem, of course, is the nerves are all passing through the spinal canal here. And so if you imagine the spinal canal as a tubular structure, and if you're looking down a tube like a telescope, if that shifts like this, if you can see my hands, if that shifts like this, then those nerves passing through there will get squished in that region. So the spondylolisthesis, that instability, creates stenosis or nerve compression. Here's the same spine on MRI. So you can see the white is the spinal fluid. We're looking at a vertebral body here, and here there's a disc. And you can see how the spinal canal, the space for the nerves, gets very narrowed at the level of the slip. And then this is a cartoon drawing of the same thing, where that instability creates narrowing of the spinal canal right here. And then that nerve root compression causes, again, the symptoms you're familiar with, sciatica and neurogenic claudications. So again, with spondylolisthesis, what we're really dealing with is another form of stenosis, nerve compression, but this stenosis is due to instability. You again initiate conservative management, which is physical therapy, analgesics, anti-inflammatory medications, and potentially spinal injection. But if someone has failed conservative management, then you would offer them potentially surgery. Surgery in this case can be approached a number of different ways, which we'll discuss in a moment. The laminectomy, or the decompression portion of the operation, is done from the back, as previously described for stenosis, opening the spinal canal. But then, because there is instability, if you take away the ligaments and disrupt some of the muscles in the back, you can make that instability worse. And so when there is spondylolisthesis, that is where fusion would be warranted, meaning rods and screws. So you can see on this cartoon drawing here, we have the bone, the disc, bone, disc. We've taken away some of the material in the back. So this is the front of the spine. This is the back of the spine. We've removed the back. That's the laminectomy, decompressed. We put the hardware in. These are the screws. They're made of titanium. Sometimes we'll put a cage in the disc space as well. And this is an X-ray of what a fusion looks like. In this case, the metal appears white. The bone appears gray. You can see the disc spaces above and below kind of look like an empty space. And there's a cage in this disc space here, depicted by these two vertical lines. There's a plastic cage with bone graft in it. And there's multiple different ways that a fusion can be achieved. This is the most traditional way, which is with pedicle screws. I will say that pedicle screws have really only been around for about 20, maybe 30 years, 20 years really. Prior to that, we did what's called a non-instrumented fusion, which means no hardware, but we achieved a fusion by putting bone graft along the edges of the bone so that it could weld together in the same manner as fracture healing heals two broken bones together. Bone graft over a fusion bed will solidify as bone, and then you have what's called a non-instrumented fusion. And that's what was done historically for decades before we had hardware. And the purpose of the hardware is really to hold the spine in stable position so that the bone graft can fuse and heal, and it makes the fusion rates higher by putting the hardware in. Now, there's a number of different ways that a fusion can be achieved. I'm going to walk through some of them. Traditionally, this is a pedicle screw. Pedicle screw goes right into bone. This part of the anatomy, we're again looking at the spine in cross section. The dots are the nerve roots. And this part of the bone here is called the pedicle. And so you can access that from behind to enter the bone safely. And it's a good safe corridor because the nerves are protected as long as you stay within bone. So you can put pedicle screws at multiple levels, and then those are connected together by rods. And so you can link one level to the next, either achieving a one level or a multi-level fusion, depending on how many levels are involved with instability. This can also be done in a minimally invasive way. So traditionally, we would do a more open exposure, so we can see the entire.
Meeting OGP, she's waiting for her delivery between 3 and 4.
But we can also, under X-ray guidance, make small incisions and then place the screws through tiny poke holes through the spine, and then link them all together. So it's a less disruptive or minimally invasive technique. And these towers that you're seeing here are what help us place the percutaneous or minimally invasive screws just through tiny poke holes through the skin. There's another type of screw that we'll sometimes put called a cortical screw. And this is the same titanium screw, but it's smaller and the trajectory is different. And this is the minimally invasive version of the pedicle screw. Here you can see a traditional pedicle screw is kind of an out to in trajectory. And here you can see a cortical screw is more of an in to out trajectory. And although that difference seems trivial, you can imagine the size of the incision that you would have as you're putting a cortical screw, where you're starting in the midline and then working out. You can work through a much smaller incision to achieve that. Here's looking at the pedicle screw in cross section and from the side, and then here's the cortical screw in cross section from the side. They both work equally well. I like to do cortical screws when it's just one level because it's minimally invasive, it's small incision. But if we're doing multiple levels, then usually pedicle screws is a better choice. Now, in addition to pedicle screws, we will sometimes put a cage into the disc space. So again, the disc space is that shock absorber in between the bones. And we can get bone graft material into that disc space to facilitate our fusion. And posterior lumbar interbody fusion, or PLIF, is one approach where we come directly from the back to put these cages within the disc space with bone graft. Another approach, which we use very commonly, is TLIF, transforaminal lumbar interbody fusion. It's different. It's just a slightly different approach for the cage. And with modern technology, surgeons can place that cage from the back, the side, the front, or obliquely, depending on patient's native anatomy. The cages that we use in the disc space can be made of a number of different materials. There is bone, allograft or cadaver bone. That's not as commonly used anymore, at least in the lumbar spine. We certainly use in the cervical spine a lot. There is a specialized plastic, which is here, called PEEK or polyethyl ether ketone, which is biologically inert, and then bone graft material can go on the inside. There is a cage that is made of exclusively metal, and these surfaces are specialized on-growth surfaces, so the bone can actually grow into the cage and interdigitate. There's combinations of plastic coated with metal, and there's even expandable cages where if the disc space, if the height is very collapsed, we can put a cage in that's small, and then inside the disc space, open it up like a car jack would elevate a car, and that can create some additional height. Now, cages do not have to be placed only from the back. We can also place them from the front, and ALIF, or anterior lumbar interbody fusion. Typically, this requires an access surgeon, a vascular surgeon, who makes an exposure through the abdomen, gently moving the abdominal contents out of the way, and then negotiating or working around the important blood vessels in the spine to access the disc space. You get a very large cage in from the front, and this is what this cage would look like. And here's an X-ray depicting an ALIF, anterior lumbar interbody fusion, interbody device in the disc space, and then it can be stabilized either with a plate in the front, screws that go through the cage itself, or sometimes with screws in the back. There's also lateral interbody fusion. We can approach the spine from the side. DLIF, or direct lateral interbody fusion, XLIF, or extreme lateral interbody fusion, and OLIF, or oblique lateral interbody fusion. But this is all to approach the disc space from the side. These are minimally invasive approaches where we go through, it's called a trans-psoas approach. The psoas is the big muscle along the side of the spine. The abdominal contents stay out of the way, and then we're able to access the disc space with this speculum that allows us to view through a very narrow portal. We use X-ray guidance and neuromonitoring to make sure that none of the nerves are in the vicinity. And that's what an XLIF, or a lateral interbody cage would look like. Again, we would fill with bone graft to achieve a fusion. This is a new piece of technology that we have just acquired at Beth Israel Deaconess Plymouth. It's called BrainLab. And BrainLab allows computer navigation for our hardware. What this means is in the operating room, a CT scan. So the patient comes in, is placed under anesthesia, is positioned, and then while under anesthesia, undergoes a CT scan. And that allows us to triangulate with computer navigation in 3 dimensions where our hardware is going to go within space, so that we can be very precise about staying through a safe corridor. And of course, every patient's anatomy is different. So this allows us to navigate their unique anatomy based on their CT scan. And this was just recently acquired. This is going to be, I think, a game changer and a very powerful tool in terms of making surgeries faster, safer, more precise, and better. It's not just pedicle screws. We can achieve a lot more with it in terms of resecting regions of bone and being really precise with what we need to take and what we need to leave behind. And this really, kind of brings us into the second quarter of the 21st century in terms of spine care, where historically we were placing screws under direct visualization, then with X-ray guidance and neuromonitoring to guide us. And this is the next iteration of that, where it is computer navigated. And the goal of this is really to reduce outliers, meaning The majority of us can freehand place pedicle screws safely 99.9% of the time, but that's not good enough. It needs to be 100%, and a misplaced or misdirected screw is not acceptable. And so this will help eliminate those rare situations where the surgeon may have had trouble getting the screw in, and the computer will help us do it precisely. Now, I did allude earlier to bone graft. So when we do a fusion, the hardware, meaning the rods and screws or the cage within the disc space, is really designed to hold everything in place, but the bone graft is what's achieving the fusion. Bone graft is osteoinductive, and what that means is bone forming. There are precursor cells within the bone graft that stimulate differentiation of what are called osteoblasts, which are bone forming or precursor cells, stimulating those cells to form new bone. And you can think of fusion biology the same as fracture healing biology. When you fall and break your wrist, we put a cast on, or maybe we put a plate and screws, but the goal is to hold that fracture in good alignment so that your body can heal the fracture. And that's what a fusion is too, for having your body form new bone. So bone graft is osteoinductive, osteogenic, meaning there is living bone cells within the graft that contribute to bone formation, and osteoconductive, meaning it's a scaffold that those bone cells can then travel across to form new bone. And there's a number of different types of bone grafts that are available to us. Historically, we always used exclusively autograft, which means bone from the patient. We used to take bone from their hip, the iliac crest, where there's a lot of high quality cancellous bone, and that is still considered the gold standard. But the problem with that is there was donor site pain. We made a new incision that could get infected, and people would notice significant hip pain from where we took that bone graft. So we began to develop other types of bone graft options. Allograft is cadaver bone, which works well. And then there is man-made bone graft, synthetic things. So we don't have to use cadaver bone, and we don't have to use your bone from your hip. We can use man-made bone graft to achieve the same results. So I wanted to circle back to the three main indications for surgery in the lumbar spine for degenerative conditions. We talked about a lumbar disc herniation, we talked about stenosis, and we talked about spondylolisthesis as three entities that we might offer surgery on. And I wanted to draw your attention to this important piece of research called the SPORTS trial. SPORTS is an acronym for Spine Patient Outcome Research Trial. And this is a study that was done several years ago nationwide across 13 different sites that were high volume surgery sites. And they studied patients who had lumbar spine problems. They had a total of 2,500 patients. So this is an enormous study. And I can tell you, this is the largest and most rigorously run research study that we have in all of spine and certainly in all of orthopedics. And so although there are, people, the statisticians will debate forever the pros and cons and the merits of the study, this really is the best quality evidence that we have that spine surgery can be useful and effective. They had patients who underwent surgery versus patients who stayed with conservative management. And what that means is for lumbar disc herniation, for stenosis, for spondylolisthesis, the three entities that I described for you, everyone initiated conservative management first. They all tried physical therapy, medications, potentially an injection, but then the ones once conservative management had run its course, some were offered surgery and some were kept with continued conservative management. And what we found was for all three of these entities at long-term follow-up, 2, 4, and 7 years, and now we're at 14 years, for all of these entities, lumbar disc herniation, spondylolisthesis, and stenosis, all of these patients did better with surgery than without surgery. And that those results were long-term and durable, meaning having failed conservative management for a lumbar disc herniation, for stenosis or spondylolisthesis, the results from surgery are superior to the results for conservative management. This is patient-reported pain. This is mobility and function. This is employment. all measurable ways of determining whether someone is doing well. And these studies were published in our premier medical journals, the Journal of the American Medical Association and the New England Journal of Medicine, all in the 2006 to 2008 range. So one final sort of plug for surgery on a personal note. This is my dad and my two sons. This picture is a bit dated because my dad had his back surgery now about 4 years ago. He had stenosis. He had spondylolisthesis, just what we described. He tried conservative management. It didn't work. He had injections and therapy and so forth. It wasn't working, and he was getting quite bad sciatica. He was getting quite bad neurogenic claudications. And ultimately, having failed conservative management, he had surgery, laminectomy and fusion. He did very well. This is him leaving the hospital. Typically, it's not uncommon for people that after a fusion to stay in the hospital for 3 or 4 days, or essentially even longer. But this is him leaving in under, I think, 36 hours. He just wanted to go home. So this is us taking him home. He's had a very excellent result. He got back his mobility, his ability to walk long distances, his ability to chase my kids. Surgery very successful, not only on the 2,500 people in the sports trial, but also on a personal note. So that's all of the prepared remarks that I have for you. If I can open everything up to questions at this point, if you have any. You have on the top left of the screen our address and phone number. If these are problems that are bothersome to you, we'd be happy to see you in person to review your personal case. I will say in this format, having done these types of talks either in person or by Zoom before, sometimes we will get people who have very specific questions about their personal condition. And so I would just caution you, if that's the case, best to sort of talk in person or in the office. But if you have questions that are more of general interest to the group about back pain, then I'd be happy to try to answer.
Thank you, Dr. Leckie. Again, if anybody has any questions on Zoom or on Facebook, you can put them in the chat box. And on Facebook, you can put them in the comments section because we can see those too. We do have a question, Dr. Leckie. How has spine surgery changed in the past few years?
So that's a good question. Spine surgery in some form or another has been with us since antiquity, but we weren't really able to really do a satisfactory or good job for really the last, until we got into sort of the modern era. Historically, as I had mentioned, we were doing decompressions and non-instrumented fusions, meaning bone graft that was either cadaver bone or bone from the hip, and then no hardware. And historically, the conditions that spine surgeons were faced with are actually very different from a lot of the conditions that spine surgeons are faced with today. In the past, a big part of a spine surgeon's practice, meaning in the 50s, 60s, 70s, a big part of a spine surgeon's practice, particularly internationally, was tuberculosis and other rheumatological conditions like rheumatoid arthritis. And now, because our medical management of this is so good, we don't see those conditions as much. And so we're dealing much more with arthritic or degenerative conditions. People are living longer. Also, at least in America, people are heavier, putting more stress on the back. So the problems we deal with are different. The hardware and technology continues to improve as we demonstrated in the talk. We've got not only pedicle screws, but now minimally invasive screws, cages that can be placed from any direction. And that continues to evolve. The hardware keeps getting better and better. Additionally, the bone graft keeps getting better and better in terms of how effective it is at creating a fusion. And then equally important, our imaging keeps getting better and better too. Historically, we had X-ray, and then we had CT scan, and then we had MRI. And really, MRI is the best view, and the MRI quality gets better. So we're able to do more as we're able to see more.
Thanks, Dr. Leckie. The next question is, how effective are ablations?
So an ablation is a procedure done typically by not a surgeon, but a physiatrist or an interventional pain doctor. And in that situation, they will have worked that patient up and determined that they think their back pain is likely coming from arthritis within the facet joints. The facet joints are the small joints in the lumbar spine. I actually have in my office a small model here. So the facet joints are these small joints in the lumbar spine. And if those become arthritic, they can also contribute to back pain. And so in an ablation, the physiatrist or interventional pain doctor will do a procedure called a medial branch block, where they inject some numbing material, some numbing medication right to the facet joint under x-ray guidance. And if that temporarily makes the pain go away, then they can go in with a thermal probe and essentially disrupt or cook the nerve that goes to the facet. So it's designed for facet pain. So a facet block or an ablation can be a useful non-surgical procedure for pain management in certain situations. If the pain truly is coming from facet arthritis, then it works well. So the facet blocks, when they're not working well, it is typically because the back pain is coming from one of the other pain generators in the spine, not just the facet joints, but also potentially the disc, the ligaments, the muscles. A facet block or an ablation is a very focused or targeted treatment. And the other thing with an ablation is typically that facet, the nerve to that facet will regrow. So usually the nerve will come back after about 6 months or so. Sometimes the ablation has to be performed again. So it's a useful adjunct. It's very low risk, but sometimes it doesn't work if either it's the wrong diagnosis, or if there's more than one pain generator, or the facet pain returns because the nerve heals itself.
Okay. The next question is, with a micro disc material, does the rest of the disc area fill in the piece taken out as the material is softer, like a lung area?
Yeah, so I understand what this person's trying to say. So when you remove damaged disc material, I'll go back to that slide. Sorry. Here we are. When you remove damaged disc material, you're only removing the part of the disc that was herniated and contacting the nerve. You try to leave as much of the healthy disc as possible. Now, the one problem with these intervertebral discs is once they're damaged, they can't regrow, not unlike cartilage in a joint. So a lot of tissues in the body, once they're damaged, they can heal themselves. They can regrow or regenerate, and the disc cannot. So if there's disc material that's herniated or extruded, if we remove that, it's always gone. It will never come back, and that will always be a disc that is at least somewhat worn out. Now, that doesn't mean there's a huge cavity there that is just empty space. There will be some scarring, or it will collapse down from a more tall disc space to a one with less disc height. But it's not normal, healthy disc material that fills in there.
Okay. What types of spine operations are done in a local community hospital versus a medical center in Boston?
So really that depends on the capability of the surgeon and team at that institution, and every place is different. At my hospital, which is Beth Israel Deaconess in Plymouth, we do essentially the full gamut of spine operations, ranging from minimally invasive, smaller procedures like a disc herniation, all the way up to multi-level fusions, deformity surgery, surgery on cancer and trauma. Because we have those capabilities, we have the redundancy of highly trained staff who do a lot of this type of work. We have all of the equipment that's necessary to do it. So in my hospital, which is a community hospital, we're able to do almost all spine surgery in any form. There are certain rare situations where we may tell someone that they should go to a tertiary center. For example, certain rare types of cancer, certain types of polytrauma, meaning injury to multiple places that sort of outpace our resources, would tell someone they may have to go seek care elsewhere. But for us at the Plymouth Hospital, we're able to do essentially any type of a spine operation. And remember that tertiary care, meaning the big medical centers at Boston, like Beth Israel Deaconess Medical Center, which is our parent institution, New England Baptist, which is my practice affiliation, or the Brigham or the General, those are teaching institutions. And so although they are there primarily to take care of patients, another primary goal of theirs is to teach students and to perform research. Whereas the primary goal of the community hospital is really to focus on taking care of patients exclusively. And so it's a more of an intimate relationship between the surgeon, the patient, the staff, as opposed to a bigger institution where there's more people, including students and involved in care.
Another question, after a patient undergoes a fusion, do you worry about adjacent vertebral instability? What is the potential of additional surgical intervention being necessary?
Good question. So once a fusion is done, that changes the biomechanics of the spine. A segment that used to move no longer moves, and each of those levels that we might fuse would contribute a few degrees in every direction, flexion, extension, rotation, etc. So when you take that motion away, that naturally puts more biomechanical stress on the level above or the level below. And over the course of hopefully several years, not too quickly, sometimes that adjacent level can wear out or degenerate more quickly than it otherwise would have if it hadn't been adjacent to a fusion. And so when a fusion is performed, there is always the risk that the level above or below could wear out with time. And that is the primary reason why someone who's had a fusion may need another operation in the future. Usually when we do an operation, the level we operate on is then done and nothing further needs to be done for it. But if we have to go back years later, it's to address the level above or the level below. There are certain technical things that we do to try to reduce that risk, and we are getting better at that over the course of time with better hardware, more minimally invasive approaches. But that is always a concern. And so as I'm counseling someone, particularly someone who is younger, it's essentially a race between their longevity and their spine. And that's not different from hip and knee replacement or other orthopedic procedures. If you get a hip or knee replacement, those moving parts don't last forever and will typically have to be revised after maybe 15, 20 years. In the spine, it's the same thing. You may need another surgery. So if we're operating on someone who is, say, 75, it's less likely that they're going to need another surgery because of their life expectancy. But if we're operating on someone who's 40, it's fairly likely that during the course of their lifetime, they'll need another operation. And everyone is different. Sometimes the adjacent segment can wear out quickly. That's unfortunate when it happens, but that can happen where someone will come back on, even a year or two with the adjacent level worn out. That's not usually the case. More commonly, it's, out 5, 10, 15, even 20 years.
What is the difference between an orthopedic spine surgeon and a neurosurgeon?
So I'm an orthopedic spine surgeon, and our backgrounds are slightly different. But for most spine procedures, the type of work we do is exactly the same. So orthopedic surgeon and neurosurgeon both go to the same medical school. And then after medical school, we enter residency, which is focused training on either orthopedics or neurosurgery. Orthopedic surgeons do fracture care, meaning hip fractures, ankle fractures, etc., joint replacement, sports medicine like arthroscopy, shoulder, knee, carpal tunnel, etc. But a significant focus of our training is on spine. And then after residency, where we have general training in orthopedics, any orthopedic spine surgeon will then do an additional fellowship focused specifically and exclusively on the spine. So we're board certified in orthopedics, and then we're fellowship trained in spine surgery. Conversely, a neurosurgeon will do some spine surgery during their residency, but they also focus on other neurosurgical problems, such as the brain and peripheral nerves. And then some neurosurgeons will go right into practice on spine surgery from residency. Some of them will seek additional training, typically an orthopedic spine fellowship, to get more of the deformity and hardware type exposure. And so in some countries, such as the United States, it's about a 50-50 whether it's an orthopedic surgeon or a neurosurgeon doing spine. In other countries, such as Japan, it's almost exclusively orthopedic surgeons doing spine, and the neurosurgeons do exclusively brain. So I would say that the difference between an orthopedic surgeon who does spine and a neurosurgeon who does spine is much less significant than the difference between a good surgeon and a bad surgeon. So you can have excellent neurosurgeons, and you can have neurosurgeons that are not as good. Same thing with excellent orthopedic surgeons. Orthopedic surgeons not as good. I would say that the difference between a good orthopedic spine surgeon and a good neurosurgeon is splitting a fine hair. There's no real difference in terms of outcomes. The main or important difference is that orthopedic surgeons tend to be more handsome.
Okay. It looks like that's all the questions that we have right now.
Great. All right. Well, thank you. Thank you, everyone, for joining. If there's any further questions, please don't hesitate to reach out through the office. I'd be delighted to see any of you. We've got a continuously growing spine program with new technology, new providers coming in. And it remains a work in progress, but I'm very proud of the spine program we've been able to put together at Plymouth so far.
Thank you, Dr. Leckie. Thank you, everybody, for joining us tonight.
All right. Thank you. Good night.